All right, we discussed the difference between cardioversion and defibrillation. Yeah. All right. So last reminder. So AFib, and this is also true for A-flutter. We get to A-flutter, it'll be really quick because AFib and A-flutter have the same consequences. They look different, but they have the same effects. AFib, again, because the blood really, because there's no P waves, right? So no P waves, so the atria, are they really contracting? No. So if the atria are only quivering, so that means it's blood leaving the atria, not completely. So anytime blood pools in any part of our body, whether it's the heart chambers or in the legs or in the arms, wherever, they will form blood clots, right? So because we know that's gonna happen, so we put the patient on anticoagulants. I'll discuss anticoagulant therapy in more detail when we get to 5th semester, right, under pulmonary embolism. Another option for, yes, Libby, page number 702. Another option for AFib, especially new onset AFib, is ablation therapy. Ablation, though, is not an emergency procedure, meaning this is scheduled, okay? So before we can do ablation, by the way, is basically burning and destroying heart tissue, okay? So they will use a cautery device, an electrocautery device to find and destroy any parts of the heart that are throwing errant signals, no, abnormal signals. Because remember when we talked about the heart when we were conceived came from one stem cell, correct? And from one cell, the heart became a complex organ. Okay, some of them, as it developed, some of them became pacemaker cells, myocardial cells, pericardium, etc., heart valves. Okay, so as it developed, it became more specialized. Okay. However, when we age, because age is the #1 risk factor for AFib, correct? Okay. So as we age, some cells that were supposed to have been specialized start doing things they're not supposed to do. One of them is some of them try sending electrical impulses now. Now it's supposed to be only the 3 pacemaker cells. Okay, the SA node, the AV node, then the bundle of His all the way to the Purkinje fibers. But somehow, as we age, some cells in the atria start pacing. They start throwing electrical impulses, just like the SA node, and that's what's causing the AFib. So in ablation, we're going to destroy them by literally burning them. So the doctor will insert a catheter. Of course, this will be done in the cath lab. And then they will thread the catheter from your radial or femoral artery all the way to your heart into the right or left atrium, then burn those tissues that are throwing those erratic signals. All right, you're not supposed to do that, so we're going to destroy them. However, before you destroy them, you have to find them. So before ablation can be done, there has to be electrophysiology studies, EPS, electrophysiology study. That's still in the cath lab, a separate room though. So they'll put you in a separate room, put like 2 million electrodes, not really 2 million. They put several electrodes in your chest to try to find those erratic signals. Okay, so that once they find them, there you guys are, then they will be destroyed. Okay, then the patient goes to the cath lab, and then the patient, those cells that they find will be burned. Complication of this here. So this is what they do. High frequency, low energy sound waves are passed through the catheter, and then they will destroy those cells, right? Now, and here's EPS. Now, a complication here is, could we accidentally burn normal tissue? Yes, we could, because it's in the right atrium most of the time. Can we possibly burn the SA node? Yes, that's a possible complication. So if that happens, if the patient happens to suffer a complication from ablation therapy wherein the SA node was damaged or burned, then the patient will require a pacemaker now because there is no SA node anymore. No more pacemaker, so the patient will require an artificial pacemaker. All right. We'll skip through maze and mini maze. They're not really very common. Okay. Let's briefly discuss LAA occlusion. Now, this is an invasive therapy. So this will be done surgically. So that what they'll do, here's a picture here. So LAA is left atrial appendage. So this is the LAA. Okay. Not all people have it. Some people do, some people don't. So if you happen to have an LAA, now this is an extra appendage wherein think of it as a section in the sides of a river. You've seen a river, correct? Okay, so you see some water that gets stuck between rocks at the riverbank. Okay, so though that water doesn't move, yeah, it gets stuck there. So same idea here. So some blood gets stuck in this left atrial appendage, and that's where blood clots form. Okay, so what they'll do is close that appendage. So how do they do it? Just put a patch over there. Here, you see this mesh? So they'll put a mesh there, and then therefore blood cannot enter that area. So therefore, no more blood clots. Okay, so who gets this? The popular brand is Watchman. Okay, there are many different brands of this device. The Watchman is the most popular. So who gets it? This will be given as an option for people who cannot get anticoagulation. Or maybe we tried ablation, we tried cardioversion, it didn't work. So this will be a last resort option. Okay, again, most of people who get this option are those who cannot take anticoagulants, right? Meaning it's not safe for them to be on long-term anticoagulation. Right, any questions on this? Okay, there's really nothing we do here that we have no role, but it helps us, at least if the patient has questions, we can reinforce the teaching. Okay, so here's aflutter. So long story short, it looks like this. It looks more regular, more uniform compared to AFib. AFib was very irregular, yeah, no pattern to it. This one has a pattern. So you see it's very regular, correct? So you see sawtooth waves here. So we have here 1, 2, 3. These are not P waves. Okay? These are sawtooth waves. So this is very unique to aflutter. No other rhythm looks like this. So if you see this, a sawtooth, saw like a saw, it's sawtooth. That's aflutter. Right? Again, it's more uniform, but has the same consequences as atrial fibrillation. So since the same, then here it tells you, this paragraph tells you aflutter is treated with antithrombic therapy, rate control, rhythm control, same manner as atrial fibrillation. So no need to repeat, okay, because it's really exactly the same. All right, let's go now to ventricular dysrhythmias. We'll skip through the junctional, they're not very commonly tested. So let's stick with ventricular dysrhythmias. Let's start with PVCs. So remember PACs? Okay, so last week we talked about PACs. So these are premature atrial contractions. And what did we say always follows a PAC, a premature beat? It's followed by a pause, correct? Okay, so this one is similar. So after look at this, they are premature beats, so therefore they occur prematurely, for lack of a better word. And they're always and they're distorted, okay? They look different. So this is your regular QRS, QRS, regular. These are PVCs, okay? They look abnormal, but you see how this one is the same? This PVC, and this PVC are the same. This PVC, however, is different, correct? So if you have, because there are different patterns to PVCs. So if you have different looking PVCs, we call this multifocal. If there's the same, we call it unifocal, meaning whatever's causing these premature beats are the same source if they look the same. However, if they look different, like this one is caused by something else. These, however, that look identical are caused by the same thing. Some cell in the ventricles are causing it. Okay, so let's say the patient had a heart attack. Yeah, that's one example of when you see PVCs. See PVCs in those areas that died. Okay, PVCs can also have different patterns. For instance, this one is every other beat. Yeah, PVC, normal PVC, normal PVC. So if it's every other beat, we call it a bigeminy. It's because it's every other beat. So that's bigeminy, meaning two, okay, every other. You can also call it, if it's every third beat, meaning you have normal PVC, normal PVC, we call it trigeminy, every third beat. And we call it quadrigeminy if it's every fourth beat. Okay, so you have normal PVC, normal PVC. That's the pattern, we call it quadrigeminy. And it can also occur in succession, meaning you can have two, like this one, there's two in a row, we call it a couplet, a couple. Okay? If it's three in a row, we call it a triplet. And then four in a row, quadruplet. Now, when it's five or more, we call it VTAC now. Okay, we call it ventricular tachycardia. We don't call it like the same pattern of a term. Okay, so we only stop around quadruplet. Okay, there's no quintuplet or septuplet or whatever whatever other terms. If it's five or more, we call it VTAC now, ventricular tachycardia already. And we count how many beats of VTAC they have. Okay. We'll talk about VTAC shortly. So what are PVCs? So let's do our 5 questions again. What do they look like? So this is what they look like. What are causing PVCs? These are the causes of PVC. Coffee again. Coffee, smoking, alcohol could also be caused by ischemia. And I mentioned after a heart attack, you could also have PVCs that increase cardiac workload in heart failure that causes PVCs, or in tachycardia. Ditch toxicity, hypoxia, acidosis, electrolyte problems, especially hypokalemia, right? Signs and symptoms, there are really none, especially here. If the patient feels anything, they will just say, oh, it felt like my heart skipped a beat, because literally it did. Because remember what follows a PVC? A pause, okay? So yeah, so you'll feel like your heart skipped a beat. So if you're one of those again, drinking coffee all the time, that's what you feel, okay, when you get PVCs. So what's the intervention? Depends. Do you have symptoms or not? Okay. And what type of PVC do you have? Do you have just the bigeminy, the trigeminy? What do you have? And it's always based on symptoms. Does the patient have symptoms? You have symptoms, then we treat it. Okay. And if not, now we monitor and try to again eliminate, identify and eliminate the cause. So here, PVCs that are frequent may be treated with amiodarone or beta blockers, but long-term pharmacotherapy for PVCs is not usually indicated. That clear? All right. And teaching, of course, you teach them about the causes, especially too much coffee, smoking, drinking. All right, here's VTAC. 3 or more PVCs in a row. Although if it's 3, then that's called what again? A triplet. And then 4, quadruplet. Okay, but again, 5 or more is now considered VTAC. Okay, I wouldn't really call 3 VTAC. I mean, those 3 beats would be triplet. Okay, plus that's not really concerning. What we're concerned about if it's now 5 or more. Right? Now there are 2 types of VTAC. There's a VTAC, and by the way, that's what it looks like. Okay, this is VTAC. It depends. Because there are 2 types. Some VTACs produce a pulse, meaning is there cardiac output if you have a pulse? Yes or no? Yes, there's cardiac output, but some VTACs have no pulse. Okay, so we have VTAC, a pulseless VTAC, and we also have a VTAC with a pulse. When you have a VTAC with a pulse, that means it's a stable VTAC. You have ventricular tachycardia, but you have cardiac output because there's a pulse. However, if you're pulseless VTAC, what's the treatment again? Jim discussed this with you with your BLS? CPR and then defibrillation. Okay. Of course, the main treatment is defibrillation, but because we don't carry an AED in our pocket, so you do CPR until the AED comes. All right. Signs and symptoms depends. Is it pulseless or a VTAC with a pulse? Sorry, I forgot the causes. All right. Causes are really the same as with PVCs. However, VTAC usually is with MIs. Okay, patient has MIs during and also after an MI. Okay, so watch the patients. After a heart attack, most patients will have dysrhythmias. This is one of those. So PVCs are expected, but you watch them for VTACs because the parts of the myocardium that died become very irritable because they're dead. Okay, and then the rest of the living portions of that ventricle, of course, are they all in contact with the dead ones? Not anymore. Okay, so when you remember, let's say it's your whole muscle here, but some of the muscles here in your arm are dead. Will it move the same way? No, same thing as with the heart. Okay, so when portions of your myocardium died because of a heart attack, then you will have dysrhythmias. A VTAC is one of those serious dysrhythmias that could occur after a heart attack. Okay, management. We have medications. So these are your treatments. Of course, if it's pulseless, what's the treatment for pulseless VTAC? Okay, CPR and defibrillation. So cardioversion or defibrillation. Procainamide, these are the drugs used to treat VTAC. Okay. If it's a stable VTAC, okay, meaning VTAC with a pulse. Then we have defibrillation. When the patient has, who gets VTAC again? Okay, usually after an MI, meaning these patients survived an MI somehow, correct? Meaning they had a heart attack, they lived, they lived to see the day. But are portions of the heart dead? Yes, and then became scar tissue. So their heart has remodeled now. Okay, so the heart, they're in heart failure. So for these patients, because once portions of your heart died, are they at risk for more arrhythmias? Yes, more VTAC, more VFib. All right. So for these patients, they usually recommend, but they don't do it right after a heart attack. This is like months or years after a heart attack. Okay, several weeks after. So the patient will be a candidate for an ICD. ICD is a small defibrillator. So it's like the size of a pacemaker. In fact, you can have both. Let's say you also need a pacemaker, then it can be a dual pacemaker and ICD. So what is an ICD? It's a small defibrillator. So they put in your left upper chest with wires into your ventricles, and it will deliver shocks, electric shocks when it detects VTAC or VFib. Okay, that's what it does. Of course, it's small. Can it generate the same electrical voltage as a regular defibrillator or AED? Of course not. It's small, it's tiny, but better than nothing. Okay. Here's the second to the last ventricular arrhythmias. So one is VFib. So this is just like pulseless VTAC. There is no cardiac output here. That's what it looks like. Totally abnormal, regular, no pattern to it. So is there cardiac output here? No. And of course, are there signs and symptoms? Patient's dead. right? Well, not technically dead, but they are unconscious. Okay, so pulseless, breathless, unconscious. So sorry, I forgot the causes again. Causes, you have different causes here. So it could be MI again, or it could be untreated BTAC, can progress to become BFib, cardiomyopathy, valve disease. Okay, so you have a long list there. Treatment, what's the treatment for pulseless BTAC? CPR and then defibrillation, so same thing here. And what do you teach for VFib? Teach the patient, don't go into VFib. Okay, you die. Okay, now of course you treat and eliminate the possible cause. Last one, last ventricular arrhythmia will be asystole. So this is flat line and it's easy. Just draw a straight line. Okay, I don't have a rhythm here, but just draw a straight line, then that's asystole. So asystole, why is asystole not shockable? Why can't we shock asystole? Which is usually, I want to correct this because we see this in Hollywood movies. They always do what? When there is flat line. What do you see in movies? They shock them, right? Which is really stupid. Okay, so we don't shock asystole because there is nothing to shock. So what's the purpose of a shock? You want to convert the rhythm, right? So let's say it's beta or BFib like this. So you want to jumpstart the heart. So you want to stop the current rhythm by delivering a really strong voltage. Okay, that's what the purpose of defibrillation, because this patient is in fibrillation. Patient is in ventricular fib. So you want to interrupt this rhythm by delivering a really high voltage shock, stopping that, and then hopefully the heart will resume. Okay, so same thing with pulseless beta. Same thing with this rhythm. You want to stop this and then restart the heart. Okay, kind of like a reboot. Okay, you're rebooting the computer, you're rebooting the heart. In asystole, since there is no rhythm, so is there anything we need to convert? There's nothing to convert. There's nothing to defibrillate because the patient is in a flat line. So that's why the only treatment for asystole is what? Oh, we asystole, then do you do nothing? Oh, poor patient. Patient's full code, right? So we do chest compressions. Chest compressions only. That's all you can do. Give oxygen, give breaths, give chest compressions. Okay. Now, why do we do that? Well, we want to, in the first place, why is there a flat line? Why isn't there a P wave, a QRS, your interval, an ST segment? Why? Why not? No blood pressure, okay? No electricity. So what's the purpose of chest compressions, therefore? To generate electricity, okay? Because as long as you generate blood pressure by pumping the heart, by mechanically pumping the heart, by doing chest compressions, you are generating blood pressure, okay? So you're generating cardiac output, so is blood moving? Yes, blood is moving throughout the organs, okay? In and out of the cardiac cells. And when blood moves in and out, what is it bringing it with it? Sodium, potassium, calcium, okay? They're pumped in and out. So when they go in and out of the cell, what do they generate? Electricity, okay? So now when you do chest compressions, now you generate power, you generate electrical activity. So now the heart will return, okay? The first rhythm that usually comes back when you generate, granting that you did good chest compressions, yeah? Not like some stupid, like is doing this, playing. If you do really good chest compressions, generate good blood pressure, then you will generate BFib or BTAC. Now you can shock, all right? Okay, now we won't discuss the full ACLS. Of course, I'm only discussing chest compressions. We do give atropine, epinephrine, sodium bicarbonate, etc. Okay. However, we won't discuss that because this is outside of the scope of the textbook. Textbook does not discuss ACLS. So you'll do that another time. So after you graduate, for instance, you can get your ACLS certification, right? All right, last rhythms will be 3 heart blocks. So what are heart blocks? These are rhythms, abnormal rhythms, wherein there's a lack of or a miscommunication between the SA node and the AV node. Because they're supposed to talk to each other, correct? SA node fires, electrical impulse reaches the AV node delays the transmission, and then 0.12 to 0.2 seconds later transmits it to the Purkinje fibers down the bundle of his. Yeah? Okay, so heart blocks, there is a problem with that conduction transmission of the electrical impulse. Okay, so that's why we call them heart blocks. First degree heart block is the most harmless of the 3 because there's, and also 4, sorry, there are 4 heart blocks because there's 2 types of second degree and then a third degree heart block. So there's technically 4. First degree heart block, there is no blockage here. There's no block at all. All this is the PR interval is greater than 0.2 seconds. Okay, the delay is too long. All right, meaning the transmission was delayed too long. It took too long for the electrical impulse to travel from the AV node, SA node to the AV node. What are causing these? Usually medications, like the digoxin, for instance, beta blockers. Okay, so those are usually the causes of first degree heart block. What does it look like? So if you measure the PR interval here, PR interval is only supposed to be 3 to 5 big blocks, correct? Because it's 0.12, small blocks. Because it's 0.12 to 0.2, so only 3 to 5 small boxes. Look at the measurement here. Is it between 3 and 5? How do we measure the PR interval? From the beginning of the P wave to the before the Q wave begins. So let's say this one. So is this from here to here? Is it 3 to 5 small boxes? It's more than that. It's way more than 5 small boxes. So is this first degree heart block? Yes, that's first degree heart block. So if it's simply delayed and there's really no significant drop in the heart rate here, the heart rate may be in the high 50s, but never less than 50. Okay, because that's all it is. It just simply prolongs the PR interval. That's the only thing wrong with heart block, first degree heart block. So what do? We just find and eliminate the cause if we can. Or if you can't find and eliminate the cause, then simply monitor the patient. Make sure the blood pressure is normal, etc. Okay, any questions on first degree? Very good. Second degree heart block, type 1, this one, figure 2220. So the problem here is, yes, there's still prolonged PR interval, but it gets longer and longer. Look at it here. This is already long, gets even longer, and then you lose 1 QRS. Let me repeat. Gets longer and longer. Oh. Okay. The PR interval gets longer and longer. Here, this is already long, gets even longer and longer. Then after that third long, there will be a drop QRS. There's a missing QRS here. See? It's a P, but then no QRS. And then the rhythm goes back. So there's a normal P there, BQRST, BQRST, right? But this is second degree type 1. Is there usually symptoms here? Not really. Second degree type 1, it's also like a monitor kind of thing. Then we also identify and eliminate the cause and monitor the patient. That's it. So first degree, monitor and eliminate the cause. Yeah, same thing for second degree type 1. However, we get to second degree type 2, this is a different story now. Because in okay, here. Here's my second degree type 2. The PR interval does not get longer and longer. The PR interval stays the same. However, you're missing more than one QRS now. You're missing multiple, like this one. You're missing one here, missing another one here, missing another one here. Okay, so you're missing multiple QRS complexes now. So therefore, are the impulses from the SA node reaching the AV node consistently? No, because now, yeah, the SA node is firing, but not all of them are getting to the AV node. AV node is not getting all of them. So this is more serious now. So this is now second degree type 2. Patient definitely has symptoms here. We usually either put them on a pacemaker, meaning a temporary pacemaker, or we give them atropine. Doctor makes the decision now. Okay, we don't decide the treatment. Are we clear? The third degree heart block, however, is the most serious. Third degree heart block is this. Get my hand in marker. You can see P waves here, yeah? So there's a P wave here, P wave here. And watch the interval of the P to P. Although we're missing one P here. Is it normal? Is it regular? Sorry. No, look at the P. Okay. This P to this P. This P to this P. This P to this P. No, look at it. That P and that P. Yeah, same interval. Oh, we're missing this one. But this one and this one. Yeah, that's the same. That's the same. Okay,
Yeah.
Same regular rhythm. Yeah. Look at the QRS. Look at the R waves. R here, R here. Look at that. Exactly the same. Okay. So you have a regular P rhythm. You also have a regular R or QRS rhythm. However, does every P have an R? No. So therefore, are the SA node and the AB node talking to each other? No, because remember what I said. What are the two functions of the AB node? Secondary, and it's also a secondary or backup, right? Backup pacemaker. So this is now proof that the AV node is a backup pacemaker because it's not receiving any signal from the SA node. However, it's a pacemaker. So since it does not receive any SA node impulses, what will it do? It's gonna generate its own. Huh? Definitely not. Third degree heart blocks, the patients usually are very symptomatic, blood pressure is low. They will require a pacemaker and atropine also. Right? Meaning this is called a complete heart block, third degree heart block, also called complete heart block, also called AB dissociation rhythm or syndrome. Right? Meaning something is blocking the impulses from the SA node to the AV node. So patient has a total heart block. So as a result, you have two heart rates here. You have a different, the atrial heart rate here will be normal. It'll be between 60 to 100. However, the ventricular rate, because this is now generated by the AV node, will only be between 40 and 60. So you have a higher atrial rate, lower ventricular rate. Now, which one is more important, the atria or the ventricles? The ventricles, as evidenced by the amplitude of the QRS. So it's very strong. It actually determines stroke volume, right? Cardiac output. So what will happen here? If you have a
normal atrial rate, but then your ventricular rate is below 60. So is this compatible with life? Not enough. Okay, this will not be compatible with life. The patient will require a pacemaker, permanent pacemaker. So let's go now to pacemakers. So we'll talk about ICDs and pacemakers. Teaching will be similar. We already discussed cardioversion and defibrillation. What's the difference between the two? Because the equipment's the same, yeah? It's the same equipment that we're using. So what makes the equipment a cardioverter? You turn on the synchronized button. Once the sync button is on, when does the machine deliver the shock? At the peak of an R wave. If it's a defibrillator, when does the machine deliver the shock? Whenever you press the button. Okay, very good. Please read chart 22-5. I got questions here for your next week's exam. Okay. These are your responsibilities when you're participating in defibrillation or cardioversion. Okay, this will contain your responsibilities. I mentioned EPS earlier. We really have no role in EPS studies except taking the patient down there to the cath lab and the doctor does anything. What's the purpose of EPS again? What will this test do? Okay, this is a diagnostic procedure. Okay, so this will define the sources of the abnormal electrical impulses. That's all we need to know about EPS. Pacemakers. Now there are we'll describe 3 types of pacemakers. So we have 2 types of temporary, and then there's 1 permanent. A temporary pacemaker is the same machine we use as a defibrillator or the cardioverter. That can also be serve as a temporary pacemaker. Long ago, we had handheld pacemakers, a separate machine, but now we realize that it's not really an efficient way to spend money. I mean, we have defibrillators, so we'll just use the defibrillators. Okay? We have them already anyway. So why do we have to spend more money on a separate temporary pacemaker? It serves the same thing. Plus, we have more than 1 defibrillator on the unit. Let's say you're on telemetry unit. So like on my unit, we have at least 3. Okay, so 1 for the crash cart and then 2 for when we're transporting somebody. Okay, when we send the patient to CAT scan or whatever test, when they leave the floor, we have them on a portable defibrillator, which again serves as a cardioverter or a pacemaker. Okay. All right, so who needs a temporary pacemaker? So among the 3 heart blocks, which 2 will require, 4 heart blocks, which 2 will require a pacemaker? Second degree, type 2, and third degree heart block. Okay. Who else will require a pacemaker? Well, those who are post-op, after open heart surgery, because when we do open heart surgery, traditional open heart surgery, we stop the heart. Okay, because can you have the heart beating while you're messing with it? You do surgery, nah, we stop it, right? Okay. Although we can do a beating heart surgery now, there are skilled surgeons that can do that, okay? But not every hospital can do that. All right. When you need short-term pacemaking, that's what the temporary pacemaker for. Now, what I'm describing is an external. It's external because the wires are on the patient's skin. Okay, so we put the pads on the patient's chest, and then we turn on the machine and then set it to be a pacemaker. And it will fire small electrical impulses, which will pace the heart. And that's it. So the pacemaker wires are outside the patient's skin. Now there's also so we call that transcutaneous, no? Over the skin, transcutaneous. There's also one we call transvenous, temporary pacemaker. The difference between the two, the equipment is the same. However, the wires are now inside the patient's heart. Okay, so who would require a transvenous as opposed to a transcutaneous? A transvenous would be someone who requires a permanent pacemaker. However, we can't put it in yet. Okay, so let me put it this way. So let's say I have third-degree heart block. I need a permanent pacemaker, yeah? There's no such thing as an emergency pacemaker insertion procedure. The surgeon will not come in, the cardiothoracic surgeon will not come in and at wee hours of the night to put it in. No. Why? Because there's a temporary one. There's a transcutaneous. Does that make sense? Okay. So they'll wait until first business hour, tomorrow. Okay, I'll set it in for 9, 10 a.m. Okay. Meanwhile, put them on a temporary transcutaneous. Okay. Someone who, let's say, let's say I need a permanent pacemaker. You have a transcutaneous one on me. However, I have an infection, a blood infection currently. Now, can I have anything foreign implanted in me during an active blood infection? No, because whatever you put in me will become infected. So we have to wait until I finish antibiotics, I clear the infection, then you can put whatever you want inside me. Does that make sense? Okay. However, can I be on a transcutaneous pacemaker for a week? That would be very uncomfortable because remember, the electrical impulses will be going through my skin. So I'll feel each one. Okay. So I can probably tolerate that for a few hours overnight. However, you're asking me to wear it for a week. What will I say? No, not for a week. Okay. So for patients who require a permanent pacemaker, we can't put one in yet. So they will require a transvenous. So the doctor will insert the wires only into the ventricle. However, the machine is still outside the patient's body. Why can't we put the machine inside yet? There's an active infection. Okay, that's usually the scenario why someone would require a transvenous. And then finally, if there's no infection, no other contraindications, then you will have a permanent pacemaker, right? There's two general settings on a pacemaker. So a pacemaker will either be demand or fixed setting. When it's on a demand setting, it's a computer, right? So you can program it. When it's on demand, it will only fire impulses if the patient's heart rate falls below a set number. Now, 90% of pacemakers have a setting of 70, meaning if it falls below 70, meaning you're in your SA node, if your SA node fires less than 70 beats per minute, it will fire. But if your SA node is firing above 70, it will not fire. Does that make sense? Okay, that's demand. Okay, there's also a fixed setting. First, fixed setting is also called an override setting, meaning it's going to disregard whatever the SA node is doing. It's gonna fire no matter what your SA node is doing, right? So of course it's a machine, so which one will have a higher electrical voltage, your SA node or this machine? The pacemaker will have a higher voltage. So which impulse will be detected by the AV node or the atria? The pacemaker or the SA nodes? The pacemaker, right? Now, because when there's a pacer now, so when it's the one, by the way, it can either pace the atria or pace the ventricles. Okay, the doctor can set it that way. If it's pacing the atria, what will you see on the rhythm? You see P waves? Which fire the impulse? Pacemaker or the SA node? Pacemaker. So
If it's the pacemaker firing, will you see P waves? No. What you'll see are pacemaker spikes. So here, do you see P waves? No, now you see. Yes, you do. So you'll see this instead. So instead of the So instead of the P waves, you'll see pacemaker spikes here. So you'll see just a vertical spike. So that's it. That's all you see. And you can also see it. So this one is atrial pace. You can also see a ventricular pace. So this is a ventricular pace. Okay. So you see these. All right. So either the ventricle or the atria will be paced. All right. So you won't see P waves if it's atria. And instead of a QRS Q wave, you will see this one, a ventricular pace. All right. Any questions? All right, that's it for pacemakers. Now your responsibilities, there's a, well, this one, there's a chart, yes, somewhere. But the teaching will be in this long paragraph here. Okay, they included it here. For instance, what will you teach the patient to do here, for instance? Like if you're, because electromagnetic fields can interfere with the function. So can you use it while welding? Can you use a welder? You have a pacemaker or an ICD? No. Because this thing, any machine has a magnet, yeah? So this thing has a magnet too. And it's, although it's not totally metal, but it has a magnet, so its function can be interfered with when you're using anything with a large electromagnet. Let's say welding equipment, or let's say large speakers, those large concert speakers, those things have magnets. Okay? All speakers have magnets. Okay? What else? You should be okay with microwave. Microwave ovens are okay. Let me just show you the here. No, not that one. It's another. Some complications. It's here. Okay, right here. Chart 22-9 applies to both ICD and a pacemaker. Okay. So the title of the chart is Educating a Patient with an Implantable Cardiac Device. So it didn't say ICD, well, acronym is ICD, right? But it doesn't say defibrillator only. So this is an implantable cardiac device, which refers to both pacemaker or an ICD. Okay, so same teaching. So here, can you use a microwave oven? Yes or no? Yes, microwave ovens are okay. Can you walk through TSA security right here? security gates, airports, government buildings, you know, those anti-theft devices or those big magnets at TSA when you do this, take off your shoes. Yeah, can you use those? Okay, so tell them that you have a pacemaker and you would like to request a manual violation. Okay, you want to be violated manually, not the equipment. You know what I'm saying, right? Well, they violate you. Grab your ass, your chest. Yes. Depends on the pacemaker. Older pacemakers are metal, but those people who have them are almost gone now because we haven't used metal-based pacemakers for about 10, 20 years now. So but there are still out there. Okay, there's still some old people who still have metallic pacemakers, but not all of them are really contraindications for MRIs. Even implants, you know, dental implants, different material and it's now titanium, which is not technically metal. Okay? So they are MRI safe. Yes. Yeah, doesn't yeah, you still do the same. Yeah, plus in the first place, why did you defibrillate? Because they're in VTAC, pulseless VTAC or VFib, right? So yeah, doesn't affect. Meaning is the pacemaker firing?
So the EKG would tell you if the patient have pacemaker.
Yeah, you can see it on that. Well, not all the times, because remember I said that some pacemakers are demand. Yeah, so if the patient's heart rate is above the setting, so it may not fire. So the only way you know is you touch it. Okay. However, there's now really small pacemakers now that they, unlike the old wherein like you have here like these devices. Okay, this is the traditional pacemaker. Okay, we have leadless pacemakers now. So leadless are invisible. You cannot see them anymore because that's where they implanted the. So the patient can have a leadless pacemaker. So in that case, you can only know based on patient's history, chart, or if you ask the patient. Okay, that's where the pacemaker is. You can't feel that. That's inside the heart. You understand? So there are leadless pacemakers now, right? So not the traditional wherein you have it over the chest. So if they have a leadless, can't see it. It's inside, all right? And then you can see it only on your rhythm. Let's say you work on telemetry or you get an EKG, then you see, oh, spiking, but then you can't feel anything on the chest. So therefore, they must have a leadless pacemaker, right? Of course, these things don't last as long as because of course the smaller battery, smaller, all right? That's the end of cardiac rhythms. Any questions? Okay, let's take a very short break, just 10 minutes. Come back at 2:35.